Well, thank you very much, Andrea and Cecilia. And also, I'd like to thank Sophia for inviting me to participate in this very interesting meeting. Of course, there's no need to introduce to you a patient with acromegaly. We've already heard today the problems that acromegaly determines. But what I would like to talk about in the next quarter of an hour, 20 minutes, is what happens after curing acromegaly. That is, you've normalized growth hormone IGF-1, the MRI probably doesn't show very much anymore, and yet the patient still has problems. And that is what I'm going to concentrate on. I'll talk about body composition, the osteoarticular or bone problems these patients have, some data on cardiovascular persistent problems, metabolic, and end up with some data on cognitive deficiencies, which has already been mentioned today, and impaired quality of life. And now these are data that we developed some years ago, and we were interested in seeing what happened to the patients looking at their different components of their body composition. This is the fat, the lean body mass, and the bone mineral content in patients who had been cured from acromegaly. Well, you can see on this slide there are data on controlled patients. Wait a minute, let me do it this way. On controlled patients after surgery or after medical therapy, active patients, and compared to normal controls. And these are the data corresponding to men. And you can see that after disease control, these patients compared to the normal controls have different total body fat, lean body mass, and even though this improves compared to what happened in the active phase, they're still not completely normal. In females, these persistent problems, as far as body composition is determined, seem to normalize. So there aren't as many differences in controlled disease as we saw in men. So there appears to be a sexual dimorphism in the sense that in both genders, when disease is active, there is a decrease in body fat, but only in men is there also an increase in lean body mass. They have more muscle, let's say, as well as total mass, that would be more body weight, and bone mineral content. In women, however, when you control the disease, there is also a parallel normalization of the abnormal body composition. In men, however, after cure, they still have abnormal lean body mass, as well as total mass and bone mineral content. So this leaves them with, let's say, an abnormal body composition. However, I think more important is what happens to bone, because we know that growth hormone has an effect on bone, and this is a very recent meta-analysis. That is, what has been done here is to investigate all the publications which are available on a topic, in this case, bone in acromegaly, and one of the authors is our chairman today. And you can see the details that they looked at here, but the main conclusion is that skeletal fragility is an emerging complication of acromegaly. And they included here, well, nearly 2,000 patients from 41 studies where bone had been investigated using DEXA scanning. And these patients, importantly, have more vertebral fractures than normal population. Now, why would this occur? Well, in the first place, we must briefly remember that the bone is not a homogeneous tissue. It has mainly two components, trabecular bone and cortical bone. And the percentage of trabecular and cortical bone vary from one place of the skeleton to the other. But in the vertebra, it's mainly trabecular bone, as you can see here. In the hip, however, it's mainly cortical bone. So when you talk about skeletal problems, It depends. You really have to see where you are investigating, in which part of the body you're investigating these problems. And we have been interested in this and have more or less finalizing now a study looking into this a bit in further detail. And we must remember, as I said, that growth hormone does affect the bone. It's actually, one would say, anabolic, that is, it helps create more bone or have more bone tissue. And it also, in acromegaly, we know that the bones increase in size. And this may be a problem when evaluating bone mineral density with DEXA, because with DEXA you have 2 dimensions. But the bone, as we know, has 3 dimensions. And this is not always picked up properly when you are evaluating bone with DEXA. There are other mechanisms, for example, this one, which is quantitative CT or CT scanning, which does evaluate the bone in the 3 dimensions and can give you some further information. I'd just like to point out here that, for example, the DEXA parameters in these patients, we compared acromegalics and nicely matched controls in the hip, in the femur, and the DEXA parameters were not different between controls and acromegalics. And yet, when we looked at these QCT parameters, that is, looking at the 3 dimensions of the bone, we did see differences in the sense that acromegalic patients had lower values of both trabecular and cortical bone than controls. This was for the total hip, and then for the femoral neck, and then from other areas of the femur, you can see that the trabecular was always lower. In the case of the cortical, it wasn't always significant, but this was probably due to the fact that the number of patients is not enormous, as one would imagine. But you can see here, again, the cortical bone and the trabecular bone, compared in the darker color are healthy controls and the acromegalic patients. You can see that in the different areas that we looked at, cortical and trabecular bone were lower in acromegalics. So this does mean that patients with acromegaly do have an abnormal composition of the bone, despite having larger bones. And this is important because the bone must be resistant to fractures if we want to have a healthy life. And especially in bones which are mainly of trabecular nature, that is the spine, this does not occur in, let's say, controlled acromegaly, and does mean that these patients are more prone to having fractures, and especially vertebral fractures. And this is especially so in those patients who also have concomitant hypogonadism, as sometimes occur after treatment of acromegaly. I'd like to switch gears and talk briefly about the cardiovascular system in patients with acromegaly. We've already heard that there is an increased cardiovascular risk in these patients. And here, these authors have compared cardiovascular risk factors in patients with uncontrolled and long-term controlled acromegaly. And what they have done here is to look at the Framingham score, which takes into account a series of cardiovascular risk factors like hypertension, dyslipidemia, smoking, lipids, etc. And you can see here that in men, the acromegalic population was not different from controls, but this was not the case in females. In other words, women with acromegaly had a higher risk than the controls. When they looked at the data of this cardiovascular risk at baseline and after 12 months of treatment, there was an improvement. So this would be good in the sense that after controlling for acromegaly, their cardiovascular risk decreases. And this is also so for the hypertension and for fasting plasma glucose. You can see that after control, both the blood pressure and the fasting plasma glucose improve. So that would be good. But this does not mean that everything goes back to normal. In fact, there's also an improvement in the patient's cardiovascular risk, because you see here at baseline, there are practically the same number of patients, nearly 40% with a low and an intermediate cardiovascular risk and 20% with a higher risk. After 12 months of follow-up, most patients are in the low risk. So there is an improvement in their cardiovascular risk after successful therapy, but it doesn't disappear completely. So, as a summary on heart in treated acromegaly, in active disease there is a greater cardiovascular risk, and this improves in parallel to the improvement in blood pressure, glucose tolerance and dyslipidemia, but may not normalize completely. I'd like to talk now briefly about cognition in acromegaly. And here, these are some results that we have generated, where we looked at a psychological test which evaluates decision-making, and also looked at data related to memory, anxiety, and depression. We included here 31 acromegalics and 31 controls, and they underwent a series of psychological tests, which I will comment briefly now. This is the test called the Iowa Gambling Task, and this is the sort of screen the patient will see on a computer, and he is told that he should try to develop a strategy to get the maximum amount of money, choosing cards. It has 100 cards, and the first part of the test, he learns a strategy, because you see that if you choose from one pile or another, you can earn more or less money. Well, let's say from this test, right? He doesn't take any money home, obviously. And then the second part of the test, he has to apply what he has learned, the strategy he's learned in the first part, and then see what happens in the end. So first of all, there's a learning of the strategy, and then you have to evaluate this learning process. And what we observed in these patients compared to controls was that despite being matched for gender, age, and years of education, obviously the acromegalics had the disease and the controls didn't, and you can see here the different treatments and hormonal situation of these patients, they actually did worse. You can see here the controls that learned here the strategy and then applied the strategy. The acromegalics learned the strategy initially, but then they were unable to apply it. So in the end, they chose riskier cards and they ended up with less money. So here you can see in numbers, the patients compared with the controls had a worse outcome. They also had less memory, and this is this test, the Ray Auditory Learning Verbal Test. You can see that they had worse scores than the controls, and they also had more depression and anxiety, and this was evaluated with the Beck Depression Inventory and the State Trait Anxiety Inventory. And these were cured acromegalic patients. So from this we could conclude that impaired delayed verbal memory, more anxiety and depression is still present in cured acromegalic patients. They have an altered decision-making strategy compared to controls, and there were also multiple correlations between anxiety and depressive symptoms, indicating that this would affect the patient's performance in memory and in decision-making. And since depressive symptoms and anxiety are essentially modifiable situations, one could imagine that providing the emotional support to improve their anxiety and depression would probably help them with their cognitive deficits and long-term psychological outcome. So that is something that has already been mentioned this morning or this afternoon, and is worth considering. And what about quality of life? I know there's a session devoted to this, so I'm not going to talk about it very much, but you can see here, and these are data using a generic questionnaire, the Psychological General Wellbeing Index, where you can compare the scores in general population here on the right, and in different groups of patients with pituitary problems. We have here growth hormone deficiency and after treatment for non-functioning pituitary adenomas. And you can see that these data, which come from Manchester, the score for acromegalic patients was among the lowest. So these patients, despite being cured, still have an impaired quality of life. And one of the factors which is related with this impaired quality of life is persistent bone pain. And these are data again from the Netherlands. And here in nearly 120 acromegalics, they observed how, using in this case the disease-specific Acromegaly questionnaire, for the total score for the items related to physical dimensions or psychological dimensions, personal relations or appearance, there was a correlation with those patients who had joint pains. Those who had joint pains had worse outcome as far as quality of life than those who did not. Actually, with growth hormone, the correlation was only seen for the dimension of appearance. And this was also mentioned in one of the discussions before, that the fact that having to have monthly injections of somatostatin analog does trouble the patients tremendously, despite feeling better with the normal IGF-1. And these are data from France, from Toulouse, and here what they were able to find was that those patients who were controlled after surgery with normal IGF-1 actually had a better quality of life than those patients who were controlled, also with a normal IGF-1, but under medical therapy. And they were also able to demonstrate how control of this growth hormone IGF-1 excess improved especially the subscale, which is the one which is worse, that of appearance in this group of patients. There is another factor we must consider, which is radiotherapy, and those patients who have required radiotherapy usually have worse quality of life. And very recently, actually it's going to be published next month, another paper from the Netherlands showing, in this case, that patients are really worried about their facial appearance. And what they have shown here is that there is a significant correlation between worse quality of life and more problems with their facial appearance. And this does create psychological distress and disruptions to everyday life. So it is worth considering. Practical implications. Hormonal cure in acromegaly improves long-term morbidity and mortality, but we must remember that residual problems may persist, and being aware of this and treating them will definitely improve the patient's outcome, but not only on, say, the normal cardiovascular risk problems, but also consider their skeletal health and their neuropsychological well-being, because all this will help them have a better quality of life. And just to finish, I'd like to thank my colleagues with whom we have been working on this, and also for the support of many of you who have been evaluating quality of life in these patients, from which the patients, we have all learned such a lot. So thank you very much.